Shannon, do you have your QuickTime running? Shannon went back on mute, I think.
I did. I was telling my family members to
Shut up.
yeah, I was going to zip it, but shut up is just good. I'm like, I need you to stay downstairs and quiet because he's down there vacuuming. All right. So I have, yes, I start? Yeah, I'm recording.
Okay, so everybody's recording. Hi, this is Unlimited Access. My name is Levi.
Hi, I'm Shannon Ellsworth with Ursamin.
And I'm Julie Shapiro. I'm an emergency doctor in South Shore Hospital, just south of Boston, Massachusetts.
And so today is a first for Ursamin. We're going to have a guest. As you can tell, we've got Julie. And so Shannon and I have been doing this podcast for about a year. We're into like episode 33, 34, and we've had a lot of great conversations. But I think we've hit this threshold, Shannon, right? Where we're talking about things that we think we know a lot about. But I'm not a doctor. I don't even work in the medical industry to some extent. And you're not a doctor, but you are an expert in the industry. And so we asked if Julie could participate. Shannon, any thoughts toward that?
Yeah, no, I think that's a great way to put it. We talk a lot about articles. We talk a lot about what's going on in the industry, our opinion. I think that's where you always correct me. You're like, Shannon, your thought and your opinion. But Julie is an example of one of the doctors that I talk to regularly and where I shape my opinions based on the input. We'll start to add on patients, doctors to kind of get really input what people think as we look at what the challenges are within the industry. So thank you, Julie, for being first. This is really exciting for us.
My pleasure.
Fantastic. Well, so Julie, let's introduce you then to the audience. So Julie, you're an ER doctor, right?
That's correct.
Well, okay, so I envision ER doctors from what I see on TV, right? So there's like a building burning down, there's like crazy patients coming in and out all the time. How did you get into this? Tell us all about it. We're just really curious.
Well, that's a good question. When I started my career in medicine, I thought I would be a surgeon. My dad's a surgeon. I really loved the whole idea of doing really intricate, tiny little things. But I couldn't decide what tiny little intricate things I wanted to do. I liked everything. So then I thought, well, why don't I be some sort of generalist? But family doctors and internal medicine doctors, well, that's kind of boring to me. I wanted to have a little bit more of the building burning down scenario, like you just said. So I chose the emergency department, and it's been a great fit.
Nice.
So you've been doing that for, what'd you say, 30 years?
25 years. Let's not put me older than I actually am. I started my my actual career in 1999.
Okay. And are you in the same hospital you've been in all along, or have you moved around? Has it been like, where was your path when you first got in to where it is now?
So I started at a very little community hospital called Sturdy Memorial Hospital. That's just north of Providence, Rhode Island, in a town called Attleboro. And cute little hospital. It was a great place to work. But it was an hour away from my house. So then I got a job at South Shore Hospital, which is, I think, right now the second busiest emergency department in the state. And it's crazy busy. I've been there for just about 20 years. And I'm not going anywhere. I love it.
So crazy by crazy, I read up on the hospital before I came to visit. That's why I'm like, people that I admire, you guys have an amazing, like just the vision and the mission of the hospital, which is like high trauma center, like really probably the worst of the worst cases is the impression I got when I was reading it. And really the quality of work that you need to come out of there is like, is that what crazy means? Is it just any different problem? It might change every day, might change every minute. ER's my vision is always it's crazy.
It is always crazy. I guess there are just different degrees of crazy. There's crazy all the time, which is my current emergency department. Then there's intermittently crazy, which is, crazy. And then there's a lull and then crazy. And then, a lot of places it's never really crazy, or maybe one or two people might come in who are really sick. But we have sick and high volume patients all day, all the time. There are always a long wait of patients waiting to be seen. Our patients are incredibly sick. We have a very older, I don't understand how, but we have an older community. So we have patients who are at the end of their life, patients who are at the time when they consume the most amount of medical care and when their medical care is the most complicated. We also are not a tertiary care center, so we have to send off some of our more complex cases. For instance, we don't do bypass surgery. Sorry about that. So if we need to send someone after a cardiac cath for bypass surgery, they have to go in town. Or we don't do certain neurosurgical things or certain complex orthopedic things. So we have to manage what we can and can't do at our hospital. But we are a level 2 trauma center, and we are indeed crazy.
That's, so the idea of an ER doctor to me seems like this infinite challenging problem solving, right? Because people go into the ER with typically like they're sick. We use the word sick, but I always think of like, car accidents or other ways, but they're trying to describe their problem to you, right? I think about the times I go to the ER. So one of the funny things about this podcast is I always divulge all of my health things on this podcast, Julie. So when I go to the ER, it's typically like I've got this horrible pain, but I can't.
No HIPAA restrictions when you share, though. No
Yeah,
HIPAA.
no HIPAA restrictions. It's my HIPAA release. I'm releasing it to the. So I was like, I've got a pain over here, and I try to self-diagnose. But then the doctor asked me questions that I could have easily answered if I had been paying attention to the previous doctor, but I didn't. So I'm over here trying to do it. Is that your job? Is basically like a detective to some extent? Is that a good way to describe it?
The best way to describe it is I'm a mechanic. You bring your car into the shop. You say it's making a noise and it's slow in acceleration, and here you go. Will you just figure it out? And sometimes people have paid very close attention and they can say, well, when I'm accelerating or when I'm accelerating from 40 miles to 60 miles, I hear it, or et cetera, et cetera. And then other people like me are like, I don't know, it's just making a noise. It didn't feel right. And I brought it in and I don't know. So my job is to try to tease out what people are telling me. And in the same time, figure out what's already been done to them. Figure out what other medical problems they have, and then kind of hear all the background noise happening at the same time, and people walking in front of you down a hallway, because a lot of this unfortunately is happening in the hallway. So a lot of distractions while you're trying to be a detective.
That's interesting to think about. Sorry, Levi. It's interesting to think about that. It's not just a mechanic, but imagine a mechanic and somebody who keeps putting paperwork in front of you as you're trying to diagnose. And I think, so from your perspective, what would be the easiest? Like, so the patient, I think we talked about this before too, is not only trying to get the information from the patient who may or may not be able to share the information, but then how much information is being given. Like you say, some people will give you the whole car layout and you're like, I just need this one thing, versus, like, again, it's just got to be really challenging in that environment with all the noise and then trying to get the right information from a patient who doesn't tell you about. Again, you and I talked about my mother's experience where we would say, well, 12 years ago, this happened to my mom. Like, sometimes that's useful. Sometimes it's just information overload, and stop spilling out your entire life history.
Yeah, I think as a patient, especially someone who's in pain or uncertain or in a pretty scary environment, it's hard for them to know what information is valuable. So yes, I'd love to know if you had your spleen removed 12 years ago, but I don't want to know if you had a hangnail 12 years ago. And how are you necessarily supposed to know what I need to know? You're not a doctor. You just said that. You're just in pain and you just want to have some answers and make that pain go away.
That's really interesting. Like, how do you know what I need to know? And I think that's what, like, my next question was going to be like, what's the best thing a patient can do for you? But to your point, we don't know what you need. We aren't expected to know. So how do you not come in? So barring that, like with my mother's situation, I know I just brought in 15 years of paperwork, and the doctor said to me, he's like, I can't use that. It was just a mess. I just kind of dumped it. And I was like, and he's like, I can't use that. And I was frustrated. I had to leave with her, and it was like, yeah, better no information and just start verbally than everything and have to sort through that. It was like, it's just going to be faster. So kind of fascinating of what you have to deal with in the ER. I think it's such an And EMTs seem to resonate as well. Is very quickly, how do you get to, I mean, they're kind of at that trauma section of just making sure you can get that patient to the hospital.
Yeah.
Well, so we're already kind of jumping into the idea of where Ursamin fits into this, into the industry. But outside of this idea of information and communicating between, the patient, the caregiver, the physician, and anybody else in that provider network, do you feel there's like other problems in the industry? Like, what are some of the challenges that you have today, maybe beyond what Ursamin even does? What, just kind of like describe your thoughts on the industry as a whole.
I mean, I guess it depends on which part of the problems that you want to discuss, but I would say my biggest challenge every day is space and privacy. We don't have enough space. And as a result, people are lined up in the hallways or lined up in, back corridors. And there's also no privacy. Like I will frequently ask someone, have you had any new unusual discharge from your private parts? And the patient's like, it's a really tough environment. So I would say space. And then the next thing I would say is time. I do not have nearly enough time to spend with every patient. A, to gather the correct information, and B, to make them feel heard and cared about. Because that's my whole job, is to be a caregiver. And if I'm constantly stepping out of the way to let someone walk past, or getting a phone call, or trying to, find a place to wash my hands in between patients, just all of it boils down to not being able to spend the amount of time that you need to make a connection and make a patient feel heard and cared for.
It's really interesting that yeah, I could see that. Like they do say it's like over the ERs are all very, I think it's a really good question, Levi, that all the ERs are overloaded. So you don't have enough space. You don't have the time you want. I love that you categorize yourself as a caregiver, because I'm like, we're all caregivers. Like it's not like just because I was a caregiver, everybody's a caregiver. How do you do that? And how do you get satisfaction at what you do? Especially if you can't give them the time they need from you. Do you have tricks that you do to fix that? Or is it just, you just got to live with what you got? You either bring in more people. How do you handle that? Or you just kind of go with it?
So one of my biggest challenges have been to stay focused. So if I'm seeing a patient and there are a million things that are going on around me, how distracting is it when your doctor is like, yeah, do you have abdominal pain? It's super distracting. So one of my tricks is to try to sit somewhere close so that I'm at least eye level and have really good eye contact. But that's also just really good interpersonal skills that people need to practice. And then the next thing is minimizing those distractions. And that's, I guess, where Ursamin would come in, because if I'm spending less time trying to find information and I spend more time with information and then I can discuss it with the patient, that makes my time with that patient more valuable.
That's a really good, yeah. I think that's where we're like, hey, where can we help with the space in time? And we're constantly asking. That's why, we kind of decided to expand who joins these, is how can we add things that help? Like we learned it's the information, but then how do you then impact things? Like, does that help you get more time with the patient faster, get to use that time with your patient? Can you save, like you and I had talked about things like KPIs, is if we can save 10 minutes of information that gets, because you keep getting distracted, so that your 2 minutes is like really quality time.
Right.
That is impacting it, even though we can't necessarily change the crowdedness and we can't change the personal space, but we can make sure that like, and we were talking about that. I was like, oh my God, yeah, you're in the ER and you feel like you're being forgotten. And we feel like we have to fight for your attention. Like as I did, I got to be the patient advocate, and the doctors are already overloaded. If we can make those 2 minutes, listen, those 2 minutes, quality 2 minutes versus 10 minutes of distracted, that patient result is so different. Your comfort, like I know when I have a doctor comes in and they just give me those 2 minutes and we're like, they just give me those 2 minutes, quality information. We have a plan. Boom. I feel good. Listen, go. I don't need 20 minutes. I just need a good quality couple of minutes that we can go on and feel good about what our plan is. And you and I made a plan, like you say, eye contact, and commitment.
I will say though, that if we meaning all of the healthcare, spend more quality 2-minute or 5-minute interactions instead of poor quality 15 or 20-minute interactions, we will help solve some of the crowding, some of the privacy issues, because people will become shorter. They'll spend shorter time waiting, shorter time talking to their primary care doctor. It's all going to be good. There's nothing bad. There's absolutely no downside in having the information that you need easily at hand. And if it's easy for me to collect information, it's right there. And I can discuss it with you face to face, because I only see you once or twice during your emergency department visit, and it's high quality, then your care is going to be streamlined and you're going to go out a door. Whether you go out the door to be admitted to the hospital, to a nursing home, to a surgical center, it'll be faster.
We're moving you in and out. So one of the measurements is we're moving you in and out. To your point, you're getting to a point where you're getting, I kind of liken it to like waiting tables. We always said, like, you're trying to turn tables and you're not trying to be rude. You want people to feel like they're cherished. We love you. Great. There's a certain point when the table has sat a little too long and you're like, dude, I'm losing my tip. Now in healthcare, it's about somebody else needs care. Right. You're not losing tips, but it's the same idea that you can, and I hadn't thought of that, where like, as we look at KPIs, we're always thinking about patient measurements, but you're talking about volume of quality.
Shannon, if you wait for your food for 30 minutes.
Oh yeah, absolutely.
You're going to be at that table an extra 30 minutes. Yeah. And you're going to be hungry and you're going to be pissed off and you're going to see everybody else. And you're going to be like,
margaritas.
where is my chimichurri? I am hungry.
Yeah.
Well, where is my pain medicine? I have pain. Where is my doctor? If we're all sitting behind a computer screen, trying to find stuff and getting distracted, and if every time I walk away from your bedside to the computer and I'm getting interrupted 3 or 4 times during that 1-minute walk, because that's probably how many times I get interrupted. Dr. Shapiro, can you read this EKG? Dr. Shapiro, the patient in room 22 just vomited. Dr. Shapiro, the patient in room 2 is having a seizure. Each one of those distractions keeps me from putting your orders in, interpreting the information, and making a plan for you. And it just makes things so much easier when it's all streamlined. And we've tried in the medical field to make it more streamlined. We've carried computers around. They're lousy. They don't upload as fast. People are maybe not as computer savvy. We've tried putting computers in the patient's rooms. Patients mess with the computers. They break all the time. It's very expensive. We now have telephones that we carry around so you can reach us without us having to be standing in front of the computer screen. We text. Everything we're doing is trying to streamline our care. But really the biggest thing is you need to have you need to have a more concentrated and efficient use of your time and high quality interactions, not high quantity.
That's, to hear you say that, well, my first thought was, if we have margaritas in the ER, people will wait longer, is what I thought I heard you guys say.
Unfortunately, then they're really
Julie's got her margarita shaker. She's like, okay, I'll be back in 5 minutes, but have this. Well,
margarita in the corner.
Crowding would become a major issue if that were the case.
And what's funny is we joke, but the Well Nows have the slushy machines in the corner because the wait room times are so long that they've got slushies for the kids. Yeah, like we joke.
And all the diabetics, glucoses get crazy, and
right. You're like, that's great. Good job, guys.
You gotta bring your own little sniffer in to kind of spice up the slushy. Well, but I think the thing that stuck with me, Julie, was hearing you talk about, that model of you just sitting down, getting to eye level and just communicating. Quite frankly, even here on this podcast, I can see you're a very good communicator. And they kind of say, right, that level of care, that bedside manner, is like 90% of medicine to some extent. I'm making up my own number here. But it's like just knowing that you care and that you're listening to me makes me feel better. And yeah, that was really, I don't know, it was touching to me. I was like, yes, that simple thing of just getting to eye level, really impactful. It wasn't really a question, was it? That was,
I didn't know if I
stood out to
jump
me.
in any vibe, but I was like,
Well, I mean, it's easy for us because we're in this industry. We at Ursamin, we really care about this data sharing. I think the temptation for us here on this podcast today is to start talking about Ursamin as a solution. But what I really wanted to lean into, is just more of Julie's story, and quite frankly, Julie, that was part of your story that I liked. I don't know, so I wanted to make sure
yeah,
it was noted.
I agree. I think what we're trying to do is it's like, yeah, I'm telling other people's stories, but to hear it directly from the people who live it, like we want to get those voices out there.
Yeah.
Often it's me saying, "Oh my God, I spoke with." But I think the background, I think the passion. When I first started this journey, 90% of the people, like the ER, especially the ED, the people dealing in that stage are probably the most passionate because you're living that every day. And people go, "Oh my God, it's life or death." But it is in every stage. And I think being able to have somebody like you and your story on here to tell the story and not have it third hand is, super useful. So I'm so grateful.
When I started emergency medicine, this is actually it's quite a funny story, and it's nostalgic. But my first job at that cute little community hospital, if I had a patient who had chest pain and I had to look at their EKG, I would ask someone from the medical records department to go get their paper chart and bring it to me. Sometimes their paper chart, if they hadn't been in the hospital for 10 or 15 years, could have been in a remote location in like a storage container. So I would have an EKG. The EKG might be abnormal. I have to wait for the chart to come thunk in front of me, then go through every page to see if there is an old EKG, look at it, and try to determine what was going on with that patient at the time of that EKG to see how to compare it to the EKG I'm looking at right now and see if it's important, and see if the one that I'm looking at now has changed, and ultimately to find out if the patient's having a heart attack. So when you think we've come a really long way, but we're still not all the way there.
Yeah.
Well, we've taken a lot of your time today, and we're going to try to do a part 2 to this just for length of the podcast. But Shannon, do you have any other final questions? Because again, we're going to have a part 2. But is there anything else that we need to cover today?
No, I think this was a great start. I love the beginning story. Julie, you gave me that story when I went to visit South Shore. And again, just the people that I admire what they do, what you live with, and your passion to solve this problem. And you said, I was way back when it was Post-it notes, and it's come a long way. I think what I learned over the last 2 years is that they often say it's broken. You're like, no, look at how far we've come. And you didn't risk patient safety. And there's all these things like risk and other things that have to be calculated. It's come a long way. Now we're ready for more. And I think that's what was really interesting to me, was also the fact that everybody's like, okay. And I heard before I really started talking to doctors, well, they're hesitant. Doctors are hesitant. It was like, no, they're just not ready. Remember, the balance of patient safety and effectiveness is it's such a tightrope that you have to walk. So I think part 2 is going to be fun. This was a great way to start the conversation on what you live with every day. And yeah, thank you. That's, Levi, I'm excited about part 2. And thank you.
Thank you so much.
Well, Julie, it's so much a pleasure to have you on. This is Unlimited Access as part of Ursamin's podcast, a YouTube series where we really try to dive into these issues. And here at Ursamin, what we believe is that people, patients, everyone makes better decisions when they have access to all of that information. And that's what we really want here at Ursamin. So thank you so much, and goodbye.